for me to give you an update on what we're doing at HealthPals. Okay. So I have a co-founder, Sushant Shankar, who couldn't be here tonight, just had a baby boy, so he's living the good life right now, but he's on the technical side of our platform, has built a tremendous team, which we have here in the back of the room. So just to cut to the chase, what does HealthPals do? So if you're a health system, you would see the biggest benefit from HealthPals. It's actionable, evidence-based population management. We reduce practice variability, reduce operational costs, improve adherence to treatment protocols, and improve clinical outcomes through our platform. Our goal, our vision, is to really prevent every chronic disease. And when you talk to the CDC, especially let's talk about heart disease, they say that 80% of all heart attacks and strokes can be prevented if you can identify the risk factors early enough and treat those risk factors appropriately in the population. Easier said than done. And you need a tool that can actually help you do that. And we believe precision prevention for the masses is that tool that can achieve that kind of prevention and that kind of result. So the RAND Corporation taught us about 10 years ago that about half of all medical decisions are not evidence-based. They're actually either wrong or suboptimal based on that patient's characteristics. This is driving up the incidence of adverse events and driving up mortality and cost. We believe at HealthPals that precision prevention can drive decisions in an actionable, personalized, and evidence-based way to reduce those negative outcomes and reduce mortality and cost. It's a big market, precision prevention, but it's actually growing substantially and quickly, both in the pharmaceutical sector as well as in value-based provider sectors. At about 11% CAGR, it's about a $3 billion market right now. Our solution to this problem is something called CLINT, which is short for clinical intelligence. And I'll show you a demo of the platform in just a moment. At a high level, this is what's happening in health systems. Patients who are being seen by providers are generating lots of clinical data. They actually are sitting in the center of this data is actually administration, but they don't have any sort of way to impact the overall outcomes of their populations, of all the health systems and all the health providers within them. We believe it has to happen at the administration level. What we're doing with HealthPals is all of that medical record data, all of that patient data is being ingested by our system. And we've codified every preventive medicine guideline that's relevant for our primary care physician. And we map patient data into those preventive guidelines to produce something called a prescriptive insight, which is basically the evidence-based treatment plan for every individual patient within the health system. And we scale that to a population level and produce a population management platform that administrators can use that is actionable and granular. Built from the bottom up, it is extremely unique compared to population analytics generated by insurance claims data. In addition, we have large data partnerships, over 200 million patient life years of data, with outcomes, pharmacy, and medical record data that we use to power predictive insights using machine learning algorithms. So let me show you a demo of that platform now. Move into this space. If you're an administrator, this is what you would actually see. You would actually be able to look at any health system or clinic within your reach, and you would actually be able to choose which ones you wanted to see that data on. The patient populations, including whether they had diabetes, dyslipidemia, histories of stroke or heart attacks, and even which clinics, or even which providers. Oh, sorry. It's not going there? Oh, I'm sorry. Sorry, I'll start that again. Yeah, I might be able to. Okay, there we go. Great. So thank you. So if you're an administrator, you can choose any clinic within your health system, and you can choose any specialty as well as any patient cohort of your choice and any social determinant of health if you have that data. You can then choose which guidelines you want to apply to your patient population. You may be more preferable to the European Society of Cardiology or the American College of Cardiology, depending on where you are and who you are treating. You can even choose internal quality protocols like quality metrics, preventive screenings, and immunizations. And then once you've generated that cohort of patients, it generates a report which is based upon a dashboard. That dashboard is rich. It has every single patient in your system and can plot histograms of risk or any other parameter that you wish. But on the right, what you're actually seeing is the ability to see every single care gap within that population as it pertains to those guidelines. Shown here are medication care gaps, and you can see there are about 1,000 patients who should be on aspirin, but only 464 have been prescribed aspirin. Similarly, for metformin, about 75% of the patients have actually been given that prescription. You can actually see the opportunity to intervene with your patients. And with our predictive platform, you can drill down into individual care centers and predict what would happen if you were to actually go ahead and execute those care gaps and close them, and you would shift the risk of your curve by this much if you were to actually make those changes. This is all built from the bottom up. You can drill down to an individual patient and see that this patient has a moderate risk of heart disease. She has 6 or 5 risk factors for heart disease, 2 of which she can't change, her ethnicity and her family history. But she can change her cholesterol ratio, and if she were to not have a high cholesterol, she would actually be a low-risk patient. You can start to prioritize the impact of each intervention and therefore come up with a care plan that's actually in rank order of priority. You can actually see all of the content sources for each of these recommendations as well, the actual societies and the quality of that evidence. When we generate the report, let me try this one more time. Not working now. We actually can generate a summary for each healthcare administrator that shows a narrative of their entire population. This particular population that you've chosen has 2,100 care gaps, and most of those are medications. It allows you to focus on the impact by showing you that the cohort could have a 7% risk reduction if you went and closed all of those care gaps. In addition, you can break down the individual treatments, and you may have internal quality metrics that you're trying to meet and have met in some cases and have not in others. You can break down each individual site, and even with pharmacy data, see if something is a physician-induced gap or a patient-induced gap. For instance, a patient that never picked up their medication from the pharmacy versus a physician that never prescribed that medication. You can do that by site, and you can even use published numbers needed to treat to project the impact on the reduction in stroke over 3 to 5 years, for instance, based off of clinical trial data. Now, we're selling this product not just to health systems, but to pharma. In pharma, it has a very different interest in mind. They've spent tens of millions of dollars on clinical trials and often struggle to have their evidence-based drug being used appropriately in the clinics. So we actually are able to show them the utilization patterns of their drugs in an evidence-based way for specific conditions and specific drug types and classes. Let's see if I can show. Okay. So I'm going to go back to the deck now. Great. So how are we different than the competition? So we have a pretty vast medical content base. We started with cardiometabolic, but we've expanded rapidly beyond that to include things that are top of mind for primary care physicians: chronic kidney disease, infectious disease, thyroid disease, asthma, COPD, mood disorders, in addition to all of the cardiometabolic conditions you see here. We've added ethnicity lenses so that you can actually overlay special risk populations on this general population guideline body. And we're adding social determinants of health. We've filed several patents in this field already, and with our 200 million patient life years of data, we're using machine learning to optimize treatment pathways within the guidelines. So right now, we're scaling from 100,000 patient life years to 200 million patient life years, as I mentioned. And we have a data partnership with the American College of Cardiology to do this. We're also exploring opportunities with technology companies that will greatly expand our capture. And we believe our deal sizes will scale accordingly. So on the off chance that there are investors in the room, we are raising about $1 million right now as part of a safe note with a $10 million cap. That'll get us a 12-month runway to Series A next year to drive market adoption. And if you have any questions about that, please come see me or visit our website and shoot me an email. Thank you. Questions? Hey.
What is the reason behind the gap in therapy? Is it the lack of, or is it the doctor not prescribing it, or is it the fact that the patient is not taking it?
It could be either. And as I showed in one of these reports that you can see with pharmacy data, we can tell you which one it was.
Okay.
So it's a really important question. Still can't see the report.
It was a causal report.
Got it? Okay. So this is a breakdown here. So with pharmacy data, we can actually see the most recent prescriptions that were filled by the patient, whether they took it 1 month and didn't take it ever again. So we can start to break down what component of each gap is actually physician-induced or patient-induced.
Are you collecting any financial data, so the patient's copay, and if that's also could be impacting whether they're picking up or able to pick up the prescription, or along the same lines, prior auth with regards to different formularies on an individual plan?
So we have that ability. It really is dependent on the willingness of the health system to share some of that information. When we talk about cost information, we're using benchmarked Medicare data in order to project cost impact. But when a health system gives us more granular data about their own populations, it increases the power significantly of our analysis. It's a really powerful thing once you add that, yeah. I'm sorry.
What is this model you used? Is this a prescription kind of application, or?
Meaning, how is this actually utilized?
Yes, how do you generate revenue out of this?
Yeah, so it's a subscription plan. So we sell monthly and quarterly reports to health systems and to pharma companies, some of whom are already existing customers with some of our channel partners. Some of them are direct to HealthPals, and they, depending on the appetite that they have to see frequency of data, they may choose to do off-cycle reports as well. But they get access to a dashboard and the report that they've customized, as I shown in the demo. Is there another question over here? Yeah.
Yeah. I'm having trouble conceptualizing how you incorporate both the evidence-based guidelines that presumably come from existing publishing for AMR study, that kind of stuff.
Sure.
With the machine learning algorithm, the new data sources that you're incorporating.
Yeah.
Because it seems like you kind of, well, you must have a way. It seems
Yeah.
like one would
So,
pick the other. And
so if you look across medicine, there are a lot of companies doing machine learning and AI. Almost none of them are actually optimizing within the confines of evidence-based medicine. So if you think of the guidelines as guardrails, most of the ML AI companies in medicine right now are giving you insights that are way outside the guardrails. There isn't evidence to support doing that action. Like, if this patient eats 10 green peas a day, they won't get cancer, but there's no randomized controlled trial that's going to prove that. The guidelines have all had those. They've all had those randomized controlled trials, those evidence-based studies that have led to them being in the guidelines. HealthPals is optimizing within the guardrails of those guidelines. If you qualify for a high-intensity statin, well, there are 4 of those. Which one's best for patients like you? Going back through 200 million patient life years of data and soon to be 250 million by the end of this year, we're able to increasingly narrow down the optimal treatment pathways for individual patients and cohorts of patients within a health system. And that's going to vary based on the healthcare plans of those patients, based on the provider behaviors, based on the patient behaviors and social determinants of health. So we actually get pretty nuanced with those insights.
So theoretically, there could be an insight that comes out of the machine learning data that doesn't fit within the guardrails, and that would be tabled or ignored for the time being.
It's hypothesis generating. In addition, though, you have published numbers needed to treat from clinical trials. We're generating from real-world clinical data our own numbers needed to treat, what's actually happening in the real world, and we can show both of those at a population level.
A great answer is what's the second line diabetes drug? Metformin is the first line. What's the second line? There's no consensus. The American Diabetes Association doesn't publish what it is. Nobody says what it is. Their data could figure out if the first line is not working. What's the second line drug? What's the second line drug that you should use for this patient in this situation?
Yeah.
That's the kind of answers. And that's why Watson hasn't taken off, is because Watson's not bounded by the clinical guidelines. Watson's, a different kind of machine learning that isn't bounded by the clinical guidelines.
Yeah, that's exactly right. Yep.
One other follow-up question to
Yeah.
particular medication based on only medical knowledge. And
Yeah.
rather than calling it a gap, it could be a medical reasoning behind it.
So it's a great point. It's a healthy debate that I think we have internally. Oh, sorry, the question was the gap that we report, how do we know that there's not some other medical reason why the physician has chosen not to prescribe a drug? And I think one deliberate choice we made in HealthPals was to be broad, but not too high in those verticals of each domain. These are low-hanging fruit, quite honestly, for all of these domains, and yet they're not being done. And the RAND study suggested the reason that they're not being done, the reason that so many people are not on hypertension drugs or diabetes drugs or cholesterol drugs, is less that the physician chose not to do it, and much more that the physician didn't have time to consider that the patient should be on that medication. The average number of minutes that a physician actually sees a patient in the room at the point of care is about 10 to 12 minutes if you're lucky. And the average number of evidence-based decisions to be made for that patient are about 7 or 8, yet you're probably only dealing with 1 or 2 acute issues for that patient in that encounter. So there is simply not enough time, and the guidelines are changing every other year. The hypertension guidelines dropped from 140 to 130. How many more patients are not on hypertension medications right now because of that guideline change? So there's evidence supporting these changes, but the adoption is difficult for physicians. Over 1 million publications every year in medical journals. I can't keep up with that, and I struggle for that. I want to use this tool. So that's what I want to do for my population. So that's basically where it comes from.
How do you implement this program, and will it integrate with the existing Epic system?
So great question. We can integrate. Can we integrate with existing EMR systems, and how do we do that? Our initial engagements with health systems do not require EMR integration. We tried selling this at the point of care to individual practices, one after the other, but the acquisition cost for a startup for each customer is way too high. We've realized that de-identified population data exports from health systems is the best first step and the easiest and lowest barrier to get into that health system. And if they wish to push it to the point of care, we can easily integrate with their health systems at that point.